Mohammed Lamorde is head of the Global Health Security Program at the Infectious Disease Institute of Makerere University in Uganda. He is director of the U.S. CDC-funded Global Health Security Partner Engagement Project in Uganda and is co-investigator on the Joint Mobile Emerging Diseases Intervention Clinical Capabilities Consortium. Mohammed serves as project lead on national level projects to accelerate compliance with international health regulations. He's a fellow of the Royal College of Physicians of London and holds a doctorate degree from Trinity College, Dublin. We're delighted to have Dr. Lamorde provide an update on integrase inhibitor clinical pharmacology.
So hello everybody, these are my disclosures. So substantial progress has been made when it comes to controlling HIV, but there still remains a global challenge. Importantly, in 2019, 1.7 million people acquired HIV. So these are 1.7 million new infections. Worse, over 600,000 people lost their lives to HIV in the same year. And we have new challenges that are emerging because the demographic that is worst affected is changing. In sub-Saharan Africa, for example, 1 in 4 people that get HIV are adolescent girls and young women. And what does this mean? This means that we have to think about HIV management, treatment over their lifetimes, especially over their reproductive life. Now we have global goals, interim global goals that seek to eliminate HIV as a public health problem by 2030. But we had a tracking goal to see how well we'd be doing by 2020. And in 2020, it was expected that we would have fewer than 500,000 new infections. And you can see how far off we are from that. In terms of deaths, we are much closer, 690,000 versus 500,000. But the last component, I think, is something that is often difficult to deal with from a drug part, and that is stigma and discrimination, which continues to be prevalent in many high-burden countries. Today, we're going to be giving an update on the clinical pharmacology of INSTIs, or integrase strand transfer inhibitors. These are the newest class of HIV drugs that we have, and we categorize them as first generation and second generation INSTIs. So raltegravir and elbitregravir were approved between 2007 and 2012. And then more robust drugs, dolutegravir and bictegravir, with a higher threshold to resistance, came in as newer products between 2013 and 2018. And it's also good to remind ourselves how HIV drugs work. Ideally, you want to stop the virus from getting into a cell. And if you have entry inhibitors, that's exactly what they do. But often the virus will make it through the cell membrane and get into the cell. And then you need specific drugs that then would prevent the virus from replicating. And the virus uses an enzyme called reverse transcriptase to produce DNA out of its own RNA. And several drugs, we call them nucleoside reverse transcriptase inhibitors and non-nucleoside reverse transcriptase inhibitors. These have been older drugs that have been part of our armamentarium against HIV for decades. And what they do is they reduce the efficiency of this enzyme, either by blocking the binding pockets in terms of the nucleoside reverse transcriptase inhibitors, or by inducing a conformational change in the part of the enzyme that is responsible for catalyzing this process. Now, integrase inhibitors are different. They don't work on reverse transcriptase. Instead, they work on integrase. And then they prevent the virus from being incorporated into the host genome. Other drugs that we are more familiar with are protease inhibitors, and they inhibit the assembly of the virus as it's being produced. And also maturation inhibitors have a role in that process as well. But today we're going to focus on the red arrow, on the integrase inhibitors. And why are the integrase inhibitors important? If you look at global guidelines currently, US guidelines, European guidelines, and WHO guidelines, in all of these guidelines, integrase strand transfer inhibitors appear as components of the preferred or first choice regimens for people who are treatment naive. That is, people who have never been on treatment for HIV in the past. And the combinations that are preferred include triple regimens in Europe and in the US, but also dual regimens. So you see 3TC, DTG at the bottom of the EACS column. These regimens have fewer drug and are considered to potentially have less of side effects in terms of some of the side effects we've seen amongst the nucleoside reverse transcriptase inhibitors. But of course, when you lose one drug out of three, you're also concerned around efficacy. And we're going to talk a bit about whether these 2-drug regimens work as well as 3-drug regimens. Now, for developing countries, we tend to follow the World Health Organization's guidance. And the World Health Organization recommends triple therapy with an integrase inhibitor and specifically dolutegravir. And we'll discuss why dolutegravir specifically has been selected by WHO. Now, when we started off with antiretroviral therapy, we had several challenges. And the challenges we had included cost of drugs, complex regimens that needed to be used many times in a single day, high pill burden. We also had issues around side effects of drugs. So things like peripheral neuropathy, which is a painful condition, or lactic acidosis, we're seeing with some of the older drugs like stavudine. As we moved on and HIV control became something that you could expect when you have an efficacious regimen, ensuring that these regimens also were tolerable, have minimal toxicities, to enable people live comfortable lives, ensuring that these regimens have few drug interactions. And so you worry less about having treatment for HIV when somebody has another condition. HIV treatment doesn't undermine the treatment of another condition and vice versa. But the other thing that we really need is long-lasting regimens. These are lifelong regimens. And so you need regimens that have a high barrier to the emergence of resistance from HIV. Now, the drugs that we had in the past, the nucleoside reverse transcriptase inhibitors and the non-nucleoside reverse transcriptase inhibitors, these provided robust regimens that had been used for many patients for 10, 20 years. However, increasingly over the last 5 to 10 years, we've started to see emergence of non-nucleoside reverse transcriptase inhibitor resistance. This is resistance to drugs like efavirenz and nevirapine that really dramatically reduce the ability of those drugs to suppress HIV. So here I'm going to show 2 studies. The first study on the left has a yellow line and a blue line. The yellow line shows you a triple regimen containing dolutegravir. The blue line shows a triple regimen containing dolutegravir, and the yellow line shows a triple regimen containing efavirenz. Now, prior to the introduction of dolutegravir, efavirenz really was the standard in terms of what you give to people in first line. So this is a component of first line regimens that really was understood to be the preferred regimen at the time. But when we look at the 2 curves, you can see that the proportion of people who achieved virologic suppression with dolutegravir slightly higher, 88% versus 81%, but also the timing. Patients that were receiving dolutegravir-based regimens achieved virologic suppression much faster than people that were on efavirenz-based regimens. In fact, as early as 4 weeks for the vast majority of those that were on a dolutegravir-based regimen. And it was based on this data from the single study that dolutegravir-based regimens started to become prioritized. Now, more recently, we've had this conversation about should it be 3 drugs, or are 2 drugs enough? And so the Gemini studies here are looking at dolutegravir, but then dolutegravir with 2 other drugs versus with 1 other drug. And interestingly, as you look at this curve and look at the proportion of people that have virologic suppression, you can see that whether it was a 2-drug regimen or a 3-drug regimen, up to 96 weeks, you had really similar outcomes. And so non-inferiority has been achieved between the 2-drug regimen and the 3-drug regimen, meaning that at least for some category of people on initial treatment, we can have a regimen containing fewer drugs. Now, in terms of whether these drugs would be affordable, now dolutegravir is relatively a new drug. Bictegravir is an even newer drug. In terms of how drugs are made accessible to patients, we work often through national programs, and those national programs have to establish guidelines or recommendations for which drug would be preferred. Dolutegravir has been shown to be potentially cost-saving to other regimens, and the cost of production was considered relatively low. And therefore, there were national efforts to ensure that dolutegravir will be available to a large number of countries through, generic versions. And in addition, national programs often got resources to support procurement for dolutegravir. In 2017, UNAIDS was able to secure a low price or a price lowering agreement with the companies producing this to ensure that dolutegravir would not be much more expensive than prior regimens that people were using. And that has really been a game changer in ensuring that access would be available, particularly in developing countries. So the next question is, 1 pill once a day for INSTIs. Do these drugs give us the ability to give people dosing convenience? And then when you look at raltegravir, not exactly. Raltegravir is traditionally dosed twice daily at 400 milligrams twice daily. However, there is a new formulation where you can take 2 tablets once daily, or 1,200 milligrams of that at once. Now, that doesn't meet the 1 pill once a day rule. Elvitegravir is not really used for treatment-naive patients. Actually, it's used in combination with protease inhibitors for treatment-experienced patients, so really doesn't qualify here in this context. But when used with these other drugs, obviously, it would be in a combination of pills, which also does not give us the dosing convenience we're looking for. With dolutegravir, the dose is 50 milligrams once daily, but fixed dose combinations are actually widely available now. And these are tenofovir, lamivudine, dolutegravir combinations, but there are also tenofovir, FTC, dolutegravir combinations. And these can be administered as 1 pill once a day. Bictegravir is a newer drug, as I mentioned. Fixed dose combinations are also available. However, bictegravir is not as widely used as dolutegravir right now. And so we now have another question, and I mentioned earlier that women of childbearing potential, particularly in sub-Saharan Africa, so adolescent girls, young women, are particularly affected now by HIV, and we really need to think about treatment that works for them before they become pregnant, during pregnancy, and even after delivery. Now, before they get pregnant, what they need are HIV drugs that are effective. They can stop viral replication, prevent disease progression, but also drugs that are safe for conception. And in 2018, there was a teratogenicity alert for dolutegravir because neural tube defects were detected in a Botswana cohort. So this was a research cohort that had already been established, and neural tube defects were noted from that cohort. And a safety signal was issued by the manufacturer, the WHO, and regulatory agencies. that potentially actually slowed down the rollout of dolutegravir in many of the countries that had already adopted it. And you can imagine the significance of a neural tube defect, a safety alert. If many people on treatment are young women, telling them that if they were to use dolutegravir, there would be a potentially increased risk of neural tube defects for their children could reduce acceptability for this drug. And so that information needed to go out at the same time these drugs were being rolled out, and making it very clear that there was an increased risk. Subsequent data a year later from the same cohort showed that the prevalence really of neural tube defects had actually declined. And in this New England paper by Zash and colleagues, we can see that 0.3% became the prevalence of the neural tube defects, dropping from close to 1%. Now, the lower prevalence did not necessarily become the same as all the other options that we're seeing in that cohort. So if women were not on DTG, ART at conception, their prevalence was 0.1%. And if they were on efavirenz at conception, it was even lower at 0.04%. And so this is significant information, because while we say that the risk is not as high as we thought initially, it doesn't give us 100% confidence that there is no risk with dolutegravir. Nevertheless, based on these data, the WHO lifted its recommendation to restrict the use of DTG among women of childbearing potential. However, guidelines emphasize that the critical component here is to ensure that women receive all the information they need to make a decision as to whether to stay on dolutegravir or whether to choose another regimen. And in wealthier settings, such as in Europe, alternatives are often considered during those discussions. So if women choose to have a baby, they can then discuss with their clinician to see whether they can have access to alternative regimens. So the second category really is about pregnancy. Here, pregnancy is important because you want to know, is a pregnant woman receiving the right dose of her drug? And then there are specific circumstances that we see in young women where women present very late in pregnancy, and you need HIV treatment that works fast to ensure that the woman does not transmit HIV to her unborn baby. Now, in the first component about dose adjustments in pregnancy, studies have shown that you do not require dose adjustments in pregnancy. And the way these studies are conducted is that women are recruited in the third trimester. They start off on dolutegravir. We check to see how much dolutegravir they get in their blood after they've taken a dose. And then we bring them in again after they've had their deliveries, and then check to see how much dolutegravir exposure they have when they're in the non-pregnant state. And if the pregnant and non-pregnant state are similar, then you can assume that a dose adjustment is not necessary. And so the paper on PLOS medicine there gives an example of how a study can help us know whether or not dose adjustments are needed. The second paper, Dolphin 2, here is looking at women that present late. And here we're trying to compare a virologic suppression, how quickly they suppress viral load, depending on whether these women have been randomized to a dolutegravir-based regimen arm, or if they've been randomized to an efavirenz-based arm. And this study was published earlier this year, and it showed that the dolutegravir-based regimens resulted in faster virologic suppression. And this type of knowledge gives us greater confidence to use dolutegravir-based regimens for this specifically vulnerable group of women who, for some reason, have not sought antenatal care early, or have just found out that they're HIV positive in the late stages of pregnancy. And then regimens that suppress virologic suppression quickly can then theoretically be used to prevent transmission more efficiently to their children. Now, most of the studies have also shown that dolutegravir is relatively safe compared to previous regimens. So In previous studies, comparing efavirenz and dolutegravir, efavirenz was known to have quite a number of central nervous system side effects, which also were persistent in a subset of patients. And so, you would have receipts of information from patients saying that when I switched from efavirenz to dolutegravir, for example, I noticed that, I could see things more clearly, or I had less dizziness. Now, that improved tolerability is an important component of any new drug. So a new drug really should not create more pain than an old drug. Now, the challenge with safety is that many times as we assess new drugs through clinical trials, we start with relatively small groups of people. And so you'd have small trials in phase 2, larger trials in phase 3, but really we're talking of hundreds rather than thousands most of the time. Now, if an adverse event is uncommon and an adverse event has, say, a frequency of 1 in 1,000, you're unlikely to see that adverse event during the drug development process. And during drug development, the early phases, phase 1 to 3, you're more likely to see adverse events that are common. Now, when the dolutegravir was rolled out in Brazil, an innovation was felt that it was necessary to roll this new drug out alongside a pharmacovigilance program. That's a program to check for adverse events as the drug is being used in the wider population. I think this is really an ambitious study or project that was initiated by the Brazilian authorities. And nearly 90% of people that started dolutegravir really participated in this program. And here we see about 72,000 people participating in this program. And the 72,000 people reported over 3,000 adverse events. Now, of the 3,000 adverse events, roughly half of them were considered persistent. So in the earlier trials, we basically felt that dolutegravir will have very few side effects compared to efavirenz. In fact, that was one of the main distinguishing features. But knowledge that some of these adverse events are actually persistent is important because it gives us a sense as to whether people would be happy with those drugs, whether they'll continue to adhere to their medication. And the commonest side effects that we are seeing are similar to what was shown in the product information: nausea, diarrhea, headaches, dizziness. These are things that we should all look out for. These are the common side effects. But I think it's also important that we think about side effects that might not be as common. As we roll out these drugs to millions of people in Africa and in other countries, we start to see other side effects. Now, one of the trials, the advanced trial, noted an increase in weight. So weight gain was noted within the trial. The trial had standard of care, tenofovir FTC and efavirenz, but it also had 2 dolutegravir arms, one with tenofovir alafenamide and then tenofovir disoproxil fumarate. Both of these drugs are prodrugs of tenofovir. But interestingly, people that were using tenofovir alafenamide seemed to show a greater increase in weight over time. Interestingly, when you looked at it by gender, women were also more likely to have weight gain with dolutegravir if they were receiving tenofovir alafenamide. Now, it's not very clear why this has happened. However, the differences between regimens and by gender are clear enough for us to note that there could be an issue relating to new onset obesity after starting dolutegravir. Uganda was also one of the pilot countries that rolled out dolutegravir, and Uganda used a very ambitious rollout plan, bringing in first centers of excellence where HIV treatment was provided, but then spreading that out to all the other facilities. And in the process, over 500,000 people, for example, were transitioned to dolutegravir by early 2019. In that process, it was possible to detect, for example, other side effects. And this is an example of an uncommon side effect that we noted in Uganda. Here is a clinic as an urgent care setting, and the clinic is able to track who comes in to receive urgent care and what their diagnosis is. This is at the Infectious Diseases Institute at Makerere University. And over time, the physicians noticed that patients were presenting with symptomatic hyperglycemia and often severe forms of hyperglycemia, which was not something they had noted before. And these hyperglycemic episodes were occurring around the same time dolutegravir had been introduced to the clinic, and patients really were being switched from prior regimens to dolutegravir-based regimens. So a case control study was done, looking at those that started or switched to DTG and those that remained on their prior regimen. And all of these are patients on first-line therapy on their initial ART. And we can see that there were 16 cases amongst those that started on DTG of symptomatic hyperglycemia, and just one case amongst those that did not switch. The issue here is that when you look at the 16 patients, 15 out of 16 had severe elevations in glucose, and patients experienced other signs and symptoms in addition to hyperglycemia, including us noting weight loss from the time of DTG initiation to the time that they were diagnosed. And so what were the characteristics of the people that developed hyperglycemia? We found that it was people who were older, people who were more likely to be male, and this may have had something to do with the fact that we had slowed down the switching amongst women of childbearing potential for the teratogenicity alert that I mentioned earlier. But then also a history of hypertension, stavudine use in past regimens, and longer duration on ART were all factors that seem to be associated with the development of hyperglycemia. Notably, when you look at these characteristics, you would find that these populations would be unlikely to have been recruited in previous studies or drug development studies for dolutegravir, and you're more likely to encounter these populations in the real world. And that could also explain why this was not detected earlier. Now, another thing that the Integrase inhibitors need to show is they need to show that they have a minimal potential for drug interactions. I've extracted a photo from the European AIDS Clinical Society guidelines that really highlights drug interactions between the antiretrovirals that we have and a range of other drugs that can be administered alongside these antiretrovirals. The key thing to look at from this slide is really that green is good, red, brown shows that there is a potential interaction. And in the red box that I've highlighted, we have the 4 integrase transfer inhibitors. And you can see for raltegravir and dolutegravir, essentially you have a low potential for drug interactions with other drugs, and those boxes are generally green. And then for bictegravir and elvitegravir, there are more interactions, with elvitegravir in particular having a large number of drug-drug interactions. And the reason is elvitegravir is metabolized through cytochrome P453A4. This is a liver enzyme that is prone to induction and inhibition by a wide variety of other compounds. And so if you have a drug that is metabolized through that pathway, and you use another drug that is either an inhibitor or an inducer of that enzyme, then you end up with drug-drug interactions. In contrast, dolutegravir uses CYP3A4 just to a minor portion. Less than 8% of the total dose of dolutegravir really goes through that route. And mostly it goes through UGT1A1. And this helps to reduce its potential for drug interactions as the victim drug, but it is also not a potent inducer or inhibitor of these enzymes. I also want to point out one other aspect around INSTIs, and that is absorption. We know that if calcium ions are taken along with INSTIs, there is binding that happens that prevents absorption. And so it's generally recommended that you avoid using antacids along with INSTIs. But if you have to do that, use them, then you would want to space them apart, either 2 hours before or 6 hours later. I think the final guidance to clinicians is that you don't want to memorize these drug-drug interactions. Instead, it is better to check every time. And part of the reason why we recommend checking every time is you can have new information coming up about drug-drug interactions. You may find out that an interaction that had not previously been studied has now been studied. And so you need a drug interactions checker that updates in real time as new information is made available. And the HIV drug interactions website from University of Liverpool is an easy, convenient, and well-updated website. Another interaction that needs specific mention is dolutegravir and rifampicin. Rifampicin is one of the most potent inducers that we have of drug metabolism, and often it tends to bring down the concentrations of the drug that has been administered alongside it. With dolutegravir, studies have shown that the exposures in blood are actually reduced if you use it with rifampicin. And yet rifampicin is the cornerstone of our management of tuberculosis, particularly in developing countries. And so it was important to understand the best way to use dolutegravir in this context. Now, the WHO recommends that the dose of dolutegravir is doubled, or you take 50 milligrams twice a day instead of 50 milligrams once a day in patients that are receiving rifampicin-based tuberculosis treatment. Using this strategy, we have favorable outcomes for TB, we have favorable outcomes for HIV, and it's really one of the strategies that has been promoted really in developing countries through the WHO. In other countries, efavirenz-based regimens might be used as the preferred one, with this strategy with dolutegravir as an alternative. Efavirenz has had a very long track record in terms of efavirenz-based regimens alongside rifampicin, and this is also an option that should be used. And in this case, efavirenz can be used at the standard dose. So to summarize, integrase strand transfer inhibitors are preferred regimens for HIV, and they're increasingly being used worldwide. They do meet key requirements for dosing convenience, particularly when you look at dolutegravir in developing countries and bictegravir in developed countries. But they are highly efficacious, and on the broad scope, they seem to have a favorable safety profile. However, even drugs that have a generally favorable safety profile need to be monitored, and clinicians need to be aware of any emerging data on some of the less common side effects, things that have to do with metabolic side effects like weight gain, diabetes. These need to be tracked until we get to know more about that. And then the safety of drugs in pregnancy and during conception is also something that needs to continually be evaluated so that we know the long-term impact of the use of antiretroviral drugs, not just on the mothers during pregnancy, but also on the babies that are born. Now, additional research is really needed to understand the mechanism, the epidemiology, the outcomes and outcomes of the adverse events related to INSTIs. This is a new class of drugs, and while they are extremely beneficial, we want to ensure that if there are any concerns, that these are detected and we know the appropriate populations for which treatment optimization may be necessary. And with that, I thank you.